Thank you, Mr. Chairman. Ladies and gentlemen, I'd like to take this opportunity to thank the organizers and particularly Dr. Wanda for inviting me to this excellent meeting. Now, in the next few minutes, I'd like to try and talk about the importance of this very, very important area in heart failure, which has been neglected, particularly in our country over here. These are my conflict of interest disclosure. Now, when you see patients of heart failure in the emergency room, you find that there is a bimodal distribution of their presentation. They come, as you see here, in two groups. Patients, if you divide them at a level of about 40% ejection fraction, you have patients who have half of them higher ejection fraction and those or normal ejection fraction, and half of them have low ejection fraction. Now, if you look at this a little more carefully, you notice this is data from the Olmsted County, from the Mayo Clinic area, that there is actually a sexual or a gender predilection to this bimodal distribution. Patients with a low ejection fraction happen to be males, and those who have higher or normal ejection fraction tend to be females, as you see over here. So at least over the last few years, we've learned, one, that both types of heart failure are present in the community. Heart failure with preserved or normal ejection fraction and heart failure with depressed ejection fraction, and they are equally prevalent, at least in the United States and the Western world. We also know that there are many similarities between these patients, but there are also a number of differences between these groups, and we'll look at some of them later. We know that the patients with preserved ejection fraction actually have a very high event rates, almost same as those with patients with depressed ejection fraction. But unlike patients with depressed ejection fraction, where over the last few years we have a very rigid pathophysiology understanding, those of remodeling leading on to progressive heart failure, unfortunately in patients with preserved ejection fraction, a unifying pathophysiological area is not being worked out as yet. And finally, of course, we have no idea how to treat these patients. And because of this, a number of myths have surrounded around the whole question of heart failure with preserved ejection fraction. And in the few minutes that I have, I'm going to look at only just 5 of the misconceptions that are there. Now, the first misconception is that heart failure with preserved ejection fraction is uncommon. Indeed, it is just the opposite. It is much more common, and here's some data from Olmsted County again, going back about 30 years, and you notice how from the beginning of the 80s now to the mid-20s, there has been a progressive and linear increase in the prevalence of this condition. In our practice, particularly my practice with old patients, we have about 60% of patients with heart failure who come with preserved ejection fraction. So who are these patients? Now, here are some data. They are somewhat old. They come from Canada, from Bhatia and his colleague, and look at these. Compare those preserved ejection patients with those who had reduced ejection fractions. Notice that they are older patients, more likely to be female, less likely to have coronary artery disease or any of their sequelae, more likely to be hypertensive, have all the comorbidities that are associated with heart failure, more likely to have atrial fibrillation, COPD, anemia, and have higher blood pressure. But when you examine these patients, you cannot find any difference. They have exactly the same amount of edema, orthopnea, PND, rest edema, rest dyspnea, crackles in their lungs, their elevation of JVD, The only differences are they're less likely to have large hearts and less likely to have a third heart sound. Now, the second myth is that it's very difficult to diagnose these patients, and therefore we don't find these patients. That's the common thing I hear from my colleagues in India. The fact is it's very easy to diagnose them. It's really not very complicated. What do we need? We need the signs and symptoms of heart failure, a normal ejection fraction, and some objective of a cardiac problem. To be able to say that the signs and symptoms that we are seeing are not from obesity, not from renal failure, or from anemia, or any of those things. And so what are those? Elevated BNP, a large left atrium, or elevated end diastolic pressure, or pulmonary capillary wedge pressure. That's all is needed. Diastolic dysfunction by echo parameters are helpful, but they are not important and certainly not part of the diagnostic criteria. When you have a patient, you think he has heart failure with the ejection fraction, and you're in doubt, measure the wedge pressure, measure the end diastolic pressure. That's all you need to do. Now, the third myth often is, well, I measured his BNP, it was normal. Well, again, you can have normal BNP, and it does not really rule out heart failure with preserved ejection fraction. Here is a study from Sanjeev Shah and his colleagues from Chicago. They looked at nearly 160 patients with confirmed heart failure with preserved ejection fraction. All of them have the framing criteria for heart failure. All of them underwent a cardiac catheterization and BNP measurements, and all of them had high wedge pressures or end diastolic pressure. But when they looked at the BNP, a third of them did not have elevated BNP with less than 100 picograms per mil. These patients were generally younger, they were more obese, they had actually as high end diastolic pressure as those with high BNP, but they had better outcomes. So the conclusion is that normal BNP is present in about a third of patients who are less severe, but they are as symptomatic as those with high BNP. Now, the fourth myth that goes around is that the prognosis of these patients is as good as any other, as those with depressed ejection fraction. Wrong. Their prognosis is as bad as those with depressed ejection fraction. Here are some data from the Mayo Clinic once again, and you see the Kaplan-Meier curves of the two types of heart failure are no different. Indeed, the prognosis is as bad as that of T4 non-small cell lung cancer of stage 3B or worse. And indeed, their readmission rate, or their heart failure readmission rate, their functional decline, and their severeness of their dyspnea are no different. So they are sick patients, they have bad prognosis, and no different from those with with depressed ejection fraction. Now, this is the problem. The final myth that, of course, you have no treatment for these patients, so why should I care about them? Well, is it possible then to treat them? What is the state of art? What are the guidelines telling us? And of course, here we have a clean slate. We do not have any proven guidelines. Now, we've done a lot of work in heart failure over the last 30 years of my lifetime in this area. Here you see, going back from the late 80s right up to now, we have tested large number of clinical trials with a remarkable output for our favor of our patients. We've looked at drugs that gave us vasodilators, ACE inhibitors, angiotensin in the ARBs, beta blockers, angiotensin receptor blockers, and then, of course, all manner of devices, and pure heart rate reducing agent, vibradine, and finally, just 6 months ago, the RNA compound, the angiotensin neprilysin inhibitors. Now, we've not been lacking in doing trials in preserved ejection fraction heart failure, looking at digitalis, beta blockers, ACE inhibitors, and ARBs, and more recently, just last year, aldosterone blocker. Now, whereas in the clinical trial scenario, those with class 2 to 3 heart failure, we've had a remarkable progress, as you see from the slide. So going back to the 1990s, a remarkable reduction in the annual mortality of these patients, down to less than 6%. And fortunately, this has actually translated into the community, and you see how the mortality in the community with the use of these drugs has progressively declined. Not so for heart failure with preserved ejection fraction. Over the last 20 years or so, there has been no change in the mortality of these patients, despite the fact that we've done many more things for these patients. And the reason, of course, is that every study that we've done on these, every drug that we've tested on these patients, ACE inhibitors, ARBs, or beta blockers, have failed to give us a positive result. So the guidelines, whether they are ESC, ACC, NACE, AHA, they all say the same thing. No treatment has been shown to convincingly reduce mortality morbidity in patients with heart failure with preserved ejection fraction. Diuretics used to control salted water, as to relieve breathlessness and edema, as we do in heart failure with reduced ejection fraction, is the treatment of choice. Adequate treatment of all the comorbidities of hypertension or myocardial ischemia, of controlling heart rate in patients who've got atrial fibrillation and rapid ventricular response is what we need to do. But here, just in the year or two, has been a new kid on the block. And I think that might help us to revolutionize the therapy. Because here is a drug which we believe, at least some of us, might be useful in these people. These are mineralocorticoid receptors, and of course, spironolactone being the most important one of them. Now, in a proof of concept study done in Europe in about 400 odd patients, they looked at the effect of spironolactone, comparing it to placebo on a few proof of concept endpoints. And here are the co-primary endpoints, looking at E to E prime by Doppler, which gives you an indication of how stiff the heart is, a diagnostic feature of diastolic dysfunction. And you see, over the 6 months, which was the primary outcome, there was a significant reduction of E to E prime, but not in PO2, peak PO2. The oxygen consumption did not increase in these patients. But both the secondary endpoints, that of LV mass and of NT-proBNP, were significantly reduced. Now, even before this trial, we had, from 5 years ago, started to carry out the very large trial called TopCat, a trial sponsored by NHLBI. And you notice here, the trial was designed to determine whether spironolactone, the MRA, can produce clinical meaningful results in composite endpoint, reducing cardiovascular mortality, aborted cardiac arrest, and hospitalization for the management of heart failure in comparison to placebo. And that important inclusion criteria were, of course, that you had to have normal ejection fraction and you had to be over the age of 50, and then you had to have either a hospitalization in the previous 12 months or an elevated BNP. Large number of patients from 6 countries, including America, Russia, Georgia, Canada, and Brazil, and Argentina, took part in the study. 1-to-1 randomization, spironolactone increased from 15 to 45. The average dose was 25 milligrams of spironolactone a day, equally distributed amongst the 2 groups of 1,700 patients or so. Now, the primary endpoint showed the reduction in CV death, heart failure hospitalization, or resuscitated cardiac arrest by about 11%, but that was not significant. But when we looked at the individual components of this primary endpoint, there was a significant reduction, a 17% reduction in hospitalizations for heart failure. Now the problem was when we looked at data from the two main regions, those of the Americas, which constituted US, Canada, Brazil, and Argentina, and that from Russia and Georgia. Notice how the placebo event rate in the Georgian and Russian continent was very low indeed, whereas those of Americas was in the region which is expected. So the question arises whether these patients from Georgia and Russia even had heart failure. This is an event rate that would be seen in you and me, or a normal 60 to 70 years old man walking the street in Hyderabad. Now when we look at the effect of spironolactone on these two groups, now you find a significant, highly significant 18% reduction in that endpoint in the Americas, or patients from America, and no effect, or actually a 10% non-significant increase in mortality in these patients. And the same was true when we looked at all the other outcomes. Indeed, when we looked at cardiovascular mortality, there was a huge improvement in that outcome with an interaction p-value of 0.01, suggesting the effect on cardiovascular mortality of spironolactone depended upon whether you came from Russia and Georgia or you came from America. So to conclude the spironolactone story, treatment with it did not decrease the primary outcome in the overall cohort, but it did reduce it in the American people, but not in the Russian group. And therefore, there is urgent need for us to find other drugs. Now, fortunately, all of you probably know the fact that Paradigm Heart Failure tested the effects of an ARNI drug in patients with reduced ejection fraction with remarkable results. Here is a drug when compared with the standard of care in patients with reduced ejection fraction caused, as you see, a 20% reduction in the primary endpoint, a 20% reduction in cardiovascular death, and a 21% reduction in hospitalizations for heart failure. A remarkable story. And so we did a proof of concept study in a small number of patients with heart failure and preserved ejection fraction called the Paramount trial, looking at a proof of concept surrogate endpoint, and that was NT-proBNP. And you notice that at 12 weeks, that was the primary endpoint, there was a significant reduction in NT-proBNP as compared to valsartan, the comparator. The design was exactly as was in Paradigm Heart Failure. There were also changes which were seen in the left atrial size and left atrial width, changes in the structure of the heart. So because of that, we have now designed a trial called Paragon Heart Failure, which is going to test the effects of LCZO, RNA, the same compound used in Paradigm Heart Failure, in patients with preserved ejection fraction, 1-to-1 randomization, in a large number of patients, 4,300 plus patients. It will go on for 240 weeks. The primary endpoint is going to be cardiovascular death and total hospitalizations for heart failure. The trial is well underway, and we hope that we'll be able to give you some data at the end of next year. So conclude, ladies and gentlemen, heart failure with preserved ejection fraction is a distinct entity which is as common as that heart failure with depressed ejection fraction. The clinical characteristics of this condition overlap that of depressed ejection fraction, but the patients have a very different response to therapy. The diagnosis appeared to be made best by clinical signs and symptoms of heart failure with objective evidence of cardiac problem, such as an increase in BNP, enlargement of the heart ALA, and elevated wedge pressures and diastolic pressures. Evidence of diastolic dysfunction helps, but it is not essential. Therapy remains empirical, and guidelines suggest control of blood pressure to target levels, careful management of volume status, and we believe, and certainly I do, that spironolactone is the most promising therapy, and unfortunately we need other drugs to take care of this very